Dear colleagues, ladies and gentlemen, welcome to this view from the Thoraxcenter of the 2021 TCT meeting. The 2021 TCT meeting will be at Orlando and it will be a hybrid construction, so there is an on-site meeting ongoing and then there will be virtual content as well. So we're going to try to be there on site, but we'll see what happens. My name is Nicolas from Mieghem from the Erasmus University Medical Center. And again, it's my great pleasure and honor to present this preview together with my good friend and colleague, Joost Daemen. So Joost, we as always will do a presentation of the trials, the late-breaking trials that are of interest for us. And maybe we could kick off with FAME3.
Yeah, so FAME3 is one of the blockbusters that will be presented, and to me perhaps one of the most interesting trials. So FAME3 is a prospective international multi-center randomized controlled trial that already started in August 2014. So it is a trial that since then randomized 1,500 patients from 50 sites to either a FFR guided PCI treatment strategy or coronary artery bypass surgery for multivessel coronary artery disease. So a very interesting trial that follows actually the initial results from the SYNTAX trial way back, follows the results of the SYNTAX-2 trial that demonstrated that contemporary PCI results in significantly better outcomes and specifically significantly lower repeat revascularization rates as PCI in the strategy as performed in SYNTAX-1, so meaning the making use of physiology, imaging, and second generation DES. And that is also what will be applied in FAME3, in which all patients will be treated with the Resolute Onyx DES and a FFR guided treatment strategy. So very interesting, long awaited. The trial already started, as mentioned, in August 2014. So I think this illustrates a little bit the complexity of enrolling patients in trials like this. But results that are definitely eagerly awaited and something to look out for in my perspective.
Yeah, so far the FAME family of trials have been exciting. FAME1, FAME2,
absolutely.
and now FAME3 I think really complements the existing literature because you referenced SYNTAX-2, but of course SYNTAX-2, the comparator was basically the cohorts from SYNTAX-1. So that was not a randomized trial, and this is a full-blown randomized study. The only thing that I'm wondering is, okay, we will have coronary physiology, but in SYNTAX-2, the importance of the integrated approach of coronary physiology and invasive imaging basically was illustrated. Do you have any insights on the use of invasive imaging?
No, I assume that the use of intravascular imaging will be relatively low.
Per operator's discretion.
And will be definitely at the operator's discretion. At the other end, there's a lot of things to be said about this trial. I mean, if it's positive, everybody will say, yes, this modern strategy will work. If the trial appears to be negative, which I think will be quite hard also given the sample size and the non-inferiority design, then people will say, well, it's most likely that the IVIS might play an important role, or imaging in general, in getting better results. So there's a lot that could follow this trial that again will be performed under the perfect leadership of Bill Fearon, Bernard de Bruyn, and Nicolas.
Good.
All right. More on physiology. Briefly mentioned is the Matthias Gottberg will present the IFR Sweetheart, in this case the 5-year results. As you know, trial published in the New England Journal 2017, over 2,000 patients randomized 1-to-1 to either IFR or FFR guided PCI. Overlapping event curves up to 1 year. However, now the 5-year results will be presented. Some more sub-analysis appeared in the past years showing that if you use IFR, you perhaps treat a little bit less, which could have a potential impact potentially in LADs, but also in subgroup analysis, no clear differences. So it could be that at 5 years suddenly a difference emerges. However, I assume that event rates will remain more or less parallel up until 5 years.
Yeah, but it's the first time now that we have 5-year follow-up in this kind of setting with IFR being compared with FFR. So I kind of like it, and I think, again, it will complement the existing literature, so that's good. Yep. And then we have a big one from China.
Again, a big one from China, and that is also the second, to me at least, the second trial I'm really looking out for is FAVOR3. So FAVOR-3, as you all have heard of, is now the first prospective randomized controlled outcome trial using angio-FFR. In this case, QFR, the MEDIS algorithm, which is probably the software platform with the largest body of evidence thus far, validating it against FFR. But in this case, it's a Chinese trial which enrolled only in 1 year time 3,800 patients that were one-to-one randomized, so either a QFR guided treatment strategy or a angio guided treatment strategy. The trial is powered for superiority, so that is the second interesting feature of this trial. Since most of the competing studies, our own FAST-3 trial, but also FAVOR-3 EU, picked the comparator as being FFR and then made a sort of a non-inferiority design. This design is perhaps much more challenging in the fact that it actually assumes a over 2.5% absolute difference in benefit or in favor of the QFR guided treatment strategy. So from that perspective, I'm really looking forward to the findings, and I hope it will be positive, because this really would open up the door to angio-guided PCI, angio-FFR guided PCI. But conversely, having a 2.5% absolute difference in an endpoint that perhaps is only 6% in a contemporary FFR guided treatment strategy arm is ambitious.
Yeah. And how would you compare this study with your own FAST-3 trial that is about to kick off? Are there any major differences, or is this more or less similar?
There are, I think, two key differences. One is the fact that the control arm here is angio-guided PCI, which is more challenging, but also perhaps not completely per routine practice guidelines, as FFR is in the guidelines and has a clear recommendation in patients that are targeted in these trials. So that's why we decided to go for FFR and have the, let's say, gold standard as a reference. That is difference number one. Difference number two, and that attests maybe also to the pros of the FAVOR-3, is the fact that here the operators and the investigators really attempted to have the treatment strategy as blinded as possible. So they call it a sham. I don't know if you can call it a sham, but at least it's good to mention that in FAVOR-3, both the patients and the operators performing the procedure, as well as those assessing the endpoints, will be blinded to the treatment allocation. So that is a specific feature of FAVOR-3 that we will not pursue.
Operators will not be blinded, will they?
Not the operators, but the personnel adjudicating the events will be blinded.
Makes sense. Let's move to some structural heart. There is a TAVI trial, of course, and we are heavily involved with that study. For the first time, the 5-year follow-up data of that trial will be presented. It's a trial that compares TAVI with a supraannular self-expanding valve, the core valve, so like the older generation core valve and the first generation Evolut R, with surgery in patients at intermediate operative risk. And so you will draw the parallels with PARTNER 2, and from PARTNER 2 that was presented already 2 years ago and published in New England. The data were a little bit controversial in the sense that, the primary endpoint in terms of mortality and stroke at 5 years was no different between the two treatment arms. But then you saw an excess in rehospitalizations, in valve interventions, and even in bioprosthetic valve degeneration in favor of surgery. And that was a little bit unexpected. We have to take into consideration that PARTNER 2 dealt with the second generation SAPIEN XT. So with SAPIEN 3, better results were described and observed. But now we will move to this self-expanding device. And, it's a big trial with the mean age of the patients close to 80 years old, the STS score of 4.5, so a little bit lower risk. But then again, we're talking about 1,500 patients. So it is a big trial, and it will provide robust data in terms of of how this self-expanding platform performs against surgery. And so I would definitely look forward to the landmark analyses. What is happening between 2 and 5 years? Do we see the same signals that we got from PARTNER 2 in terms of hospitalization and bioprosthetic valve degeneration? Or is it not a class effect with TAVI, and are self-expanding valves different from balloon expandable systems? So,
no, I agree. I truly look forward to these findings. Specifically, this is the largest follow-up thus far on self-expanding valves in a population like this. So something to look out for. More on structural is partner 3.
Yeah, so partner 3 is a different patient population. We're now talking about the low-risk patients. So these patients are 6 to 7 years younger. Their STS score is below 2%, so a different patient population. Again, comparing surgery with now the balloon expandable SAPIEN 3 platform. They're looking at basically the cost effectiveness at 2 years.
Yeah.
And this is important data, for instance, in the Netherlands, because there is still a lot of debate ongoing if there should be reimbursement for TAVI in low-risk patients in our country. And the question is, why? Because, of course, in terms of the clinical outcome, we already know that TAVI was superior to surgery, at least at the 1 year at the 1 year endpoint. So I think this data can be very helpful to move the field forward, at least in clinical practice in countries like the Netherlands and also in Belgium.
Yep, absolutely. Also here, something that I think the details on the cost effectiveness will be interesting. What will be implemented in terms of support, pacemakers, temporary devices, periprocedural. How will the numerical difference in stroke be handled in a endpoint that at 2 years was not statistically different? So a lot of features that.
But let's anticipate on a win for TAVI here.
No, I agree. I agree.
Okay,
good.
So now every big meeting these days has a late breaker on renal denervation, and of course you are the renal denervation guru here in the Netherlands. So what can we expect at TCT?
So also this year at TCT, an interesting update on the renal denervation trial program. In this case, the RADIANCE Trio 6 months results will be presented by AJ Courtney. So let me take you back a year or 2 years when we presented the RADIANCE Solo results. So patients with hypertension taken off drugs and randomized sham-controlled 1-to-1 to either RDN with the Recore Paradise technology or sham. A 2-year positive study, minus 6 millimeter mercury difference in blood pressure. And then at 6 months in the solo cohort, we found that in the sham arm, 85% were put on drugs following a standardized stepped care antihypertensive treatment regimen application, versus 64% in the RDN arm, which was a statistically significant difference, telling us that in the RDN arm you use lower numbers of drugs, but you still at 6 months had the lower blood pressure as the sham arm, which was very interesting. Now in Trio, we are dealing with a resistant hypertensive population on a fixed triple pill, so completely different patient population. Patients on 3 antihypertensive drugs, standardized, and we know at 2 months very high compliance rates. But then also these patients between 2 and 6 months needed to follow the stepped care antihypertensive treatment escalation protocol per the hypertension specialist. So what I think at first is interesting to see if also here there will be dramatic changes in drug therapy. If you think back on Solo, where there was an 85% change from 0 to 85%, how will that be in Trio where everybody was already on 3 drugs? And second, how will that affect blood pressure at 6 months and total drug burden at 6 months? So something that I think is interesting and should be interpreted in the light also of the Solo findings and the fact that the primary endpoint of this trial was at 2 months.
But we're talking about 136 patients. Is it embedded in the RADIANCE hypertension trial family?
Yeah.
Oh, okay. Now
so the RADIANCE hypertension trial had 2 arms, the Solo arm and the Trio arm. Both separate trials, but same leadership, more or less same protocol in terms of follow-up, etc.
Okay. I think it will establish, hopefully, a little bit further the role of renal denervation.
Absolutely.
And again, also here, reimbursement is something that needs to be put on the table these days.
Yeah. Closure devices, multiple sorts.
Yeah, so let's go first for large bore arteriotomy closure. And the first one, the first trial or the trial that we want to highlight here is the CHOICE closure. CHOICE closure is a single center trial coming from Leipzig. And they are enrolling 516 patients within 1 year. So the trial started in June 2020 and it ended in July 2021. So it is a China-like speed of enrollment. And they are comparing a MANTA plug-based closure with suture-based closure.
That sounds familiar.
It sounds very familiar because we did the same thing in the MESH trial. This was a smaller study at 205 patients randomized to the same two groups, and we did not find a significant difference in terms of the clinical endpoint, the primary endpoint of any vascular complication. Well, this is the same endpoint that they're using, but we found some differences between the two strategies. Numerically, we had a little bit more events with the MANTA. On the other hand, we had many more bailout interventions required in the suture-based closure. So that will be an interesting aspect of the study. Well, first, will they see a difference in the primary endpoint of any vascular complication because they have a larger sample size? And then second, how is that in terms of bailout? The only difference is, or another difference, is that CHOICE is a single center trial, whereas MESH was, of course, two centers. It was Rotterdam and it was Toulouse. But I think this will add to the body of literature, and I hope that at one point we will be able to define the patients who would be served better with suture-based and others with plug-based closure. And I assume that if we would start pooling the data, then we might have the answer.
Yeah. All right, good. More on closure devices. A bit lower, a bit higher up in the body, actually.
Yeah, so now let's go to the closure of the LAA, left atrial appendage closure. This is also a hot topic in the latest larger meetings. And we had at ESC the Amulet IDE trial, where they compared basically the two big products, so the Amulet device versus the Watchman device in over 1,800 patients, and the results were remarkable, to say the least. So the primary endpoint was driven on residual leakage, and that turned to be happening in more often after a Watchman versus Amulet, although the numbers were quite low.
98 versus 95.
Yes, so it's very low numbers.
And overall good results with both devices.
Yes, although there were more procedural complications with Amulet. So I think from that point of view, this Swiss Apero is an interesting study. But you know, the thunder was a little bit away because of the Amulet IDE, because the Swiss Apero is a smaller study. It includes only 200 patients versus 1,800 patients in the Amulet IDE, but they have the same endpoint. So let's see whether they also find or establish the superiority of the Amulet device. And then let's see if there is a procedural penalty. And I think another difference maybe between the two trials is that in the Amulet IDE, they only use the first generation Watchman technology. And so the question here is, are they using the Flex technology in Swiss Apero? I'm not sure. So we're going to learn that at TCT. And then maybe the last on structural, we take it away from closure devices, is the Apollo trial. The Apollo trial evaluates the Intrepid device, Medtronic's Intrepid technology for TMVR, transcatheter mitral valve replacement. The Apollo trial is a very ambitious project, including more than 1,000 patients with severe primary or secondary MR. There is also an embedded cohort with mitral annular calcification. And then it looks into this Intrepid technology, which is for the time being a transapical device. With an outer stent for fixation, an inner stent that contains a 27mm bovine pericardial valve. And the primary endpoint at 30 days is mortality, rehospitalization, and the absence of improvement in KCCQ. I'm not sure whether they already completed the trial, so that will be a novelty. And then, of course, we're going to see how transapical approach behaves in a larger set of patients. Of course, the competition here is the Tendyne device, which is a totally different concept than Intrepid. With Tendyne, the results have been excellent, just excellent in terms of safety. But I think patient selection plays a role here. We'll see how patient selection was in Apollo. But
And for Mac, it could be an interesting concept, which I think for Tendyne is perhaps...
Well, Tendyne has now also some promising data in terms of Mac, but the unfortunate part for us Europeans is that, of course, the Intrepid technology is not yet available. whereas Tendyne is. And then, I think Intrepid is working towards a transfemoral platform, and I hope that by the time they have created that one, that they will also embark in the European market.
That would be nice.
Yes.
Yeah.
So let's wrap up this presentation on the late breakers of TCT and move to a STEMI trial.
Yeah, so one final trial we would like to highlight is the Erosion 3 trial. This is, at least to my perspective, an interesting one. It's a randomized controlled trial, randomizing, I think, 246 patients presenting with STEMI to either a OCT-guided treatment strategy or a angio-guided treatment strategy in patients with early vessel patency. So what does this mean? At first, patients that are eligible for enrollment are those with TIMI-3 flow and a stenosis less than 70% after or at presentation or after aspiration thrombectomy. At that stage, they can be randomized 1-to-1 to OCT-guided PCI or angio-guided PCI.
So that's a selected set of patients then.
Selected set of patients. But then the interesting thing is that this trial is not just about sizing based on OCT. This trial is actually based on lesion characterization based on OCT. So you do your OCT and you look what is the cause of the luminal narrowing or the STEMI, which could also, as we know, be a calcified nodule. It could be with a small thrombus. It could be a SCAT. It could be a erosion. It could be a ruptured plaque with a residual minimal luminal area of 7. And the key question here is, do these lesions warrant stenting? Mm-hmm. And the hypothesis here is that in a specific number of lesions in these STEMI patients, you will refrain from stenting. Simply because the luminal area is large enough, there's just a small erosion, the plaque is ruptured, large cavity but no large residual plaque volume, which of course will be complex to adjudicate on OCT. But still, that is also reflected in the endpoint of the trial, which is not outcome but rate of stenting. So that is original.
A little bit of soft endpoint though.
A little bit of a soft endpoint, but it's as a proof of concept to me interesting, and at the end might have implications for future studies on, for instance, non-Coupet vessel treatment in STEMI, and it might have some further sequelae in future trials.
But what it clearly also shows is that there is a need for invasive imaging studies in the context of STEMI. And I think we need to learn more about plaque characterization, also thrombus burden. And guess what? That's what you're doing also in the Spectrum trial here in Rotterdam, where we are evaluating these thrombotic lesions with IVUS to get more insights into that. Okay, thank you very much, Joost.
Thank you.
This is going to be an exciting TCT. Again, not only because of the hybrid construction, but also because of its content. We gave you a preview. I hope you enjoyed it. We'll be back after TCT with the results of the late breakers. Thank you for attending. Thank you, Joost, again, and we'll see you after TCT.
Thank you. Bye-bye.
Bye.